So you're retracting your statement?
Yes, you got 1 more minute, Charlie.
Oh, okay, no problem, it's fine. Yeah, that's it. Yeah. So UNE is very important because we're worried about the mass that can compress the urethras as well. So it can a huge difference. So we're running out of time. Yeah, let's go, Dr. Moed.
The investigations done, the bedside investigation was a dipstick which showed 2+ ketones. The glucose was normal. Pregnancy test was positive with a HB of 7.5, and ABG was not found in the file. Blood FBC, the HB was 8.7 with a platelet of 145 and a white cell count of 7.08. Sodium, even E, we had a sodium of 138, potassium of 0.7, and chlorine of 104, a urea of 2.9 with a creatinine of 50. We also did booking blood, RH positive, she was TR negative, and RBD non-reactive. Imaging with the pelvic ultrasound. Then the pelvic ultrasound, it was the report was a normal bladder, a single intrauterine fetal pool around 7 weeks, noted with a positive fetal heart. There was free fluid noted in the pelvis. A complex mass measuring 10.3 by 9.3 centimeters was noted on the left adnexa extending to the midline. The mass was semi-cystic, plus it was semi-complicated with pre-clots and in keeping with the possible torsion or ectopic pregnancy that was ruptured.
How big again? 7 by?
Yeah.
The measurements?
Oh, the measurement it was 10.3 by 9.3 centimeters.
So what else did it say at the top right of the scan?
Yeah, if the scan there, why do you get the differentials?
Something in the note.
Normal ovaries, does it say what?
The normal ovaries were not visualized. Please correlate with HCG.
Okay, stay there. Get your differential.
Most likely, from ultrasound findings, I'm thinking of a ruptured hemorrhagic ovarian cyst, or even though it's rare, maybe
Is there free fluid here? I missed it.
there is, yes, there is free fluid, yes. Because she's anemic and there is free fluid, so I'm thinking ruptured hemorrhagic ovarian cyst, or even though it's rare, maybe a heterotrophic pregnancy and the other pregnancy is ruptured.
Yeah, we can move on.
So the most likely diagnosis was a heterotrophic pregnancy or ovarian cyst accident, hemorrhagic or torsion. Then how do you manage this patient?
Ishma?
I think the first thing would be to resuscitate the patient, so make sure she has 2 IV lines on afterwards, maintain her max above 65. We'd also want to cross-match involve the consultants and for theatre. We'd want to counsel the patient on the likely diagnosis. At this stage, we're considering bone differentials, but she's acutely ill with a peritonitic abdomen, so she needs theatre, and we would confirm our differentials in theatre. We would have taken the beta ECG as well pre-operatively to assist us post-op in the differential of whether it was heterotopic or an ovarian accident. Yes, so we'd counsel her, allow her time to take it all in, discuss with the family whatever she needs, and obviously also counsel her on the risk of possible loss of the intrauterine pregnancy. So once we have done our pre-operative planning, then we will take her in for lab and deal with what we find there. So if it's an ovarian or a fixal mass, then we need to remove it, deal with the hemoperitoneum. And then post-op, it would be care in a high care setting. We send off whatever we get for histology.
Okay, Dr. Maluleka, when it comes to operation, laparoscopy versus laparotomy, we choose. And be careful, Dr. Ramphal is behind you.
Well, in terms of what to choose.
Ovarian cyst in pregnancy with huge cyst, straight laparotomy or laparoscope, which one is the best and why?
It depends on the cyst and the availability of the expertise to perform laparoscopy. In a patient who is hemodynamically stable, with in good hands, you would opt for minimally invasive. But in a patient who is unstable with a large cyst, because sometimes we want to make it will be difficult to take it out. We may need to suction or use a bag to suction the contents of the tube. And also if it's mostly solid, it might be a challenge. So it depends on the patient and the size of the cyst and the stability of the patient. So in this patient, I would go for.
Thank you very much, Dr. Maluleke. Let's move on.
Management, the patient was resuscitated and managed in high care setting. And then counseling was done on the diagnosis, the implications of the index pregnancy, that she might have a miscarriage, consent for surgical procedure, and need for blood transfusion. So the challenge again was laparoscopy versus laparotomy, the safety, complications, and benefits, and the need of expertise for more, especially with the large masses.
Yeah, can move on. Yeah, this was the intra of findings. Dr. Maluleke, can you describe what you see?
I see sort of a mass that is solid with clots or it's hemorrhagic with some clots.
Is the tissue look viable or non-viable? For the sake of time.
So intra-op findings, there was a large ruptured ovarian cyst, peritoneum of 500 mL, normal right ovary plus tube. Left oophorectomy was done. Specimen was sent for histology.
He wants to see do something. I don't know. I'm just waiting to hear what he says. I think we'll let you know how it Ruby asked yesterday.
Can we tell those people to meet themselves? Who are they?
Go back to your intra-op, yeah? What is missing on your, I know you're summarizing, but tell us more.
In terms, let's
Left ruptured ovarian cyst, hemoperitoneuum, right ovary tube is fine. Left oophorectomy specimen sent. You didn't mention the tube on the side that is affected. So we are not sure whether it's okay.
Is the tube not there with the specimen? I think the tube is there. Is it not there? I saw something that looks like a tube anyway.
Yeah, the tube was with the specimen.
Yeah, there's a meeting coming up.
Move on.
Yeah, let's move on.
Histology results. So macroscopy, it was an open mass weighing 281 grams, measuring 12 by 7 by 6 centimeters, attached tube with fimbria measuring 6 centimeters. There was a separate tube measuring 0.8 centimeters. The mass was hemorrhagic and cystic. Microscopy, there's extensive hemorrhagic infection and exudate was seen. There are no granulomas, infective pathogens, no malignancy. There is a representation of paratubal cyst. On conclusion, it was extensive hemorrhagic infection. No viable tumor is presented. Fallopian tube tissue and paratubal cyst also seen.
Okay, thanks very much, Dr. Moele. Dr. Bridgeland will be taking us on theory, unless if there is any question, we'll be entertaining the questions.
Sorry, can I just make a comment? Why wasn't oophorectomy done? You know, what's the age of this patient? So she's a young patient in the reproductive age. And most probably this patient had an ovarian cyst, underwent some degree of torsion, and obviously ruptured and must have had some bleeding. So obviously if the patient is bleeding from an ovarian cyst, means it's active tissue, means the tissue is viable. Dead tissue doesn't bleed. So at times, you know, even when we operate with ovarian cysts in pregnancy, especially at laparoscopy, you know, you can have torsion. And what we do is we untorsion and we wait and we watch. And needless to say, you'll see the perfusion changing. And most individuals will say, even if the tissue looks infarcted, try to save the ovary, be conservative. So to me, what looks like infarcted tissue, especially with pregnancy, and maybe an associated torsion, it's very seldom I would go ahead and do an oophorectomy or an adnexectomy. It's to untorsion, even in this type of patient, because of the giveaway here is the patient is bleeding. Dead tissue doesn't bleed.
Yes, my question, because you didn't describe the operation at all.
Yeah,
What
this is
was
the
found?
first thing, yeah.
Was it torted or was it just bleeding?
It was just bleeding, but there was no.
It had bled.
There was
It
not.
no
Yeah,
longer-
there was no. It was not actively bleeding.
No, it had bled. It was no longer bleeding.
Yeah, it was no longer bleeding. There was a clot that was sitting there, and then there was no torsion at all.
There was no torsion, it had bled and clot had organized.
That's why it stopped bleeding. It's because there was a clot that was sitting there. That's why it stopped bleeding.
So why was oophorectomy done? That's what I'm saying, you know. If there was no bleeding, take off the clots and just debride the area and that's it.
Yeah, there was a huge mess. We had to do it because there's a huge mess that was around 10 by 12 centimeters sitting there. You could not try to even evacuate the mess. If you evacuate the mess, you could have started even bleeding from there.
Look, I've taken big cysts in pregnancy, even 20 centimeters bleeding in pregnancy. I mean, I must present my videos and show you. You can suction it, right? Once you decompress, right, you'll notice if there's no bleeding, just leave it. The point that I'm trying to drive at is that in pregnancy, you can get a false sense that it's very sort of hemorrhagic. And sometimes a clot can look like an infarct or like infarcted tissue. But you know, to remove an ovary, remember the ovary is not forgiving, you know.
And how much of the mass, this big mass, was clot and how much was tissue? Or did you just take it all out and then?
I think in the interest of time, the take-home message is that people shouldn't just rush and try and take out just what's bleeding. You need to be saying, this is a young patient, you can enucleate even that area that you see and then leave some ovarian tissue if possible. The tube has been taken in a setting where people suffer from whatever, PID tubes and whatnot. So really, I think the message is that registrar shouldn't just say, this is bleeding, I take out. You need to apply yourself. Can I untwist? Is there viable tissue? Can I leave some ovarian tissue behind? Can we even cautery? I know cautery will destroy further ovarian tissue, but half a loaf is better than no bread. Now here we've got, I can't remember what her age is.
26, you see.
Huh?
26 years.
Yeah, we've got a 26-year-old with the whole adnexia taken out. I think that's the take-home message, that we shouldn't just say, okay, it was bleeding, it was big, then we take it. Of course, Dr. Ramphals at laparoscopy would nucleate much better with better vision and what, but taking time and not just rushing in, especially if she wasn't shocked, this patient, she was still stable. So preservation of whatever ovarian tissue plus the tubes as well.
Okay, thanks very much for the comment. Dr.
Well, another comment is that I think a point that was brought up, and you put it down there, with laparoscopy versus laparotomy. No doubt laparoscopy is far superior than laparotomy. However, I take the point. If you don't have equipment and you don't have expertise, the better option is to be safe and do a laparotomy. The advantage of a laparoscopy, if you're doing it, is, or some of the safety measures, is you come from the left upper quadrant. Secondly, is that you operate at low pressures, no uterine manipulation. Remember, you got magnification.
I think
And you operate with all
you're
your
taking the
quads high up.
presentation away from the.
No, it's not taken away. I think the registrars need to learn this.
No,
This
no,
case has come up
That's what
in
we
the
need to
part two.
present. That's
in
what
an
we
hospital.
need to present. This, the next.
And those are the
presentation.
things that we'd ask, but I'm just giving them the points before they proceed, you know.
No,
You
we
take
don't
your
have time.
precautions.
15
There
minutes.
is a presentation, there is a.
Can you give the registrar
a group
prepare a
coming in and
presentation,
update.
folks?
You see, the point of miss out in these meetings is
Registrar,
all this you can read in the
who's
textbook,
presenting?
as I'm concerned.
Of what?
All this ovarian cyst in pregnancy, open any textbook, you'll get it. Right, the thing is that it must be a clinical approach, looking at the pros and cons of the different management and the decisions you take. It must be clinically oriented, not theoretical.
Thank you very much, Dr. Ramphal, for the comment. Dr. Bridgeland, the floor is yours.
Okay, good morning, everyone. I'll be presenting ovarian cyst in pregnancy. So, introduction. The incidence of adnexal masses during pregnancy is 0.2 to 2%. The incidence of malignant adnexal masses in pregnancy is 2 to 10 per 100,000 pregnancies. Due to an increased number of ultrasound scans done in pregnancy, there is high incidence of asymptomatic ovarian cysts diagnosed. Benign masses account for the majority of masses diagnosed in pregnancy, most of which are mature cystic teratomas, corpus luteum cysts, and cyst adenomas. Most ovarian cysts remain small in pregnancy and will not affect the pregnancy. So malignancy is not the only risk associated with adnexal masses, and adnexal mass in pregnancy can be complicated by torsion, rupture or bleeding or infection, or labor obstruction. Masses that persist into the second trimester are at risk for torsion, rupture, or labor obstruction. Incidental adnexal mass at cesarean section ranges between 1 per 200 to 1 per 400 and mostly benign. So pregnancy-associated changes of ovarian masses. When a pregnant patient presents with a symptomatic adnexal mass early in pregnancy, an ectopic pregnancy must always be excluded, since an undiagnosed ectopic pregnancy may have a potentially lethal outcome. Other pregnancy-associated masses are benign and typically present as bilateral cysts, except for luteomas who present as unilocular solid masses. The most common pregnancy-associated ovarian masses are functional cysts, like the corpus luteum of pregnancy and theca luteal cysts. Most of these cysts will resolve after the first 14 to 16 weeks of gestation. Some, like the theca luteal cyst, can persist until after delivery. Masses still present after 16 weeks of gestation are predominantly non-functional. So adnexal masses, 95 to 99% are benign, and those include the corpus luteal functional cysts, mature teratoma, endometrioma, serous cyst adenoma, mucinous cyst adenoma, paraovarian cyst, and leiomyoma. And then 1 to 5% are malignant, which consist of the germ cell, epithelial, and sex cord stroma, and 1 to 2% are borderline, so serous borderline, mucinous, borderline. Types of ovarian cysts: physiological cysts, which include follicular cysts, corpus luteal cyst, hemorrhagic cysts, tend to regress spontaneously without any intervention in most cases. Follicular cyst generally occurs due to failure of inovulation or failure of mature follicle to spontaneously rupture, resulting in a follicular cyst. They are generally simple in nature, less than 6 centimeters in size, and the majority will resolve by 16 weeks of gestation. So corpus luteal cyst. The corpus luteum is responsible for the secretion of progesterone in the early first trimester until the placenta assumes responsibility for this. They generally tend to regress by 8 weeks of gestation. Failure to recognize a corpus luteal cyst can result in unnecessary intervention. This can predispose to miscarriage in the early first trimester if it is removed. So this is an image of a corpus luteum cyst. Hemorrhagic cyst. Acute bleeding into a cyst can result in hemorrhagic cyst. It is associated with abdominal pain. The majority of cases, the symptoms are brief and temporary. If stable, it is prudent to manage conservatively. They usually benign and can have a varied sonographic appearance. Occasionally, the resolving blood clot within a hemorrhagic cyst may be mistaken for a solid nodule. Doppler studies on ultrasound will help differentiate the two, as blood clot will not show any vascularity, as opposed to a solid nodule signifying malignant potential. In rare cases, surgical intervention may be required for severe acute hemorrhagic resulting in hemodynamic instability. So, ultrasound image of an hemorrhagic cyst. Pathological cysts generally do not resolve over time. They can be benign or malignant. These include mature cystic teratoma, dermoid cyst, or malignant ovarian cysts. So mature cystic teratoma, most common benign ovarian cysts found in pregnancy. They're generally asymptomatic when less than 6 centimeters. They are prone to torsion if larger than 6 centimeters. Complication, malignancy occurring in up to 2%, 80% of which are squamous cell carcinoma. Hypothyroidism resulting from teratomas with thyroid hormone secreting tissue, and chemical peritonitis following spontaneous or iatrogenic dermoid rupture. So, sonographic appearances of a mature cystic teratoma, focal or diffuse hypoic component, areas of acoustic shadowing, also known as the tip of iceberg sign, echogenic lines and dots, also referred to as a dermoid mesh or dot dash sign. The hypoic component termed the Rockenzie nodule typically corresponds to mixed hair and sebaceous material or calcification, sometimes related to a bone or tooth. Floating echogenic globules in a large mass is an uncommon appearance, but is reported to be highly predictive of a dermoid. So this is an image of a dermoid cyst. Endometrioma are usually readily detectable by ultrasound. Cystic lesions with diffuse low-level internal echoes, sometimes described as ground glass, with 95% of endometriomas having this appearance. Endometriomas may resemble hemorrhagic cysts. However, repeating a scan in 6 to 8 weeks usually results in resolution of a hemorrhagic cyst. MRI can be helpful in the assessment of endometriomas, particularly if there are concerns with regard to malignant transformation of the cyst. So malignant ovarian cysts. Most ovarian cyst adenomas do not undergo malignant degeneration into carcinoma. Even if transformation does occur, it is usually into borderline neoplasm or low-grade malignancy, and the rate of transformation is exceedingly slow. Malignant ovarian cysts include borderline ovarian tumors, epithelial ovarian tumors, germ cell tumors, sex cord stromal cell tumors, and metastatic deposits from other primary tumors. Ovarian cyst unique to pregnancy, theca luteal cyst, decidualized endometrioma, luteoma of pregnancy. Theca luteal cysts, these cysts are frequently associated with gestational trophoblastic disease. They are also may be found in pregnancies complicated by fetal hydrops. These cysts mimic ovarian neoplasms as they often appear as multiseptated or as multiple adjacent cysts. The bilateral nature of these cysts and their known clinical associations help suggest the diagnosis. Decidualized endometrioma. These are rare but important to diagnose as they may also raise unnecessary concerns about ovarian malignancy. These lesions are often cystic and associated with small and solid components with internal blood flow detectable by Doppler studies. Unfortunately, color Doppler cannot differentiate between a decidualized endometrioma and ovarian malignancy. Further imaging like MRI are important in helping diagnose and manage them correctly. Luteoma of pregnancy. This is a rare benign ovarian cyst of pregnancy that has no specific sonographic features. It may be associated with maternal virilization. The presence of hirsutism and raised serum androgens can help in the diagnosis. So adnexal masses in pregnancy. Potential non-ovarian masses include pedunculated fibroids, hydrosalpinx, or para-ovarian cysts. Fibroids appear as heterogeneous solid masses. Hydrosalpinx present more as a tubular-shaped structure. A hydrosalpinx can be difficult to distinguish from a malignant neoplasm due to the presence of nodules and thick endosalpingeal folds. Para-ovarian cysts are common incidental finding and do not have any clinical significance. So clinical assessment. Most patients are asymptomatic. In rare cases, a patient will have an acute problem due to the torsion or rupture. Some ovarian cancers may present acutely, such as rapidly growing malignant germ cell tumors, ruptured and hemorrhagic granulosa cell tumor, As pregnancy advances, the likelihood that a large cystic mass will rupture tends to increase. The most common symptom described is sudden onset of lower abdominal pain. Clinical symptoms are mainly due to peritoneal irritation. The pain often begins during strenuous physical activity, such as exercise or sexual intercourse. It's often lasting less than 24 hours. Other symptoms may include nausea and vomiting caused by visceral reaction due to peritoneal irritation, vaginal bleeding, weakness, and syncope. Identification of a pelvic mass can be difficult because of the increased uterine volume. If a pelvic mass is identified, a complete physical examination is required. The first step is to exclude bladder dysfunction with retained urine. Tumor markers in pregnancy. Pregnancy alters the serum levels of certain tumor markers, making their interpretation in pregnancy difficult. CA125, alpha-fetoprotein beta, HCG, and LDH. So CA125, the levels of this tumor marker are raised in normal pregnancy because it is produced by the deciduum. Levels are highest in the first trimester with gradual decline as gestation advances. Threshold of 35 is often used in a non-pregnancy state in helping determine the risk of pregnancy. Levels of up to 112 may have been suggested as normal in pregnancy up to 14 weeks of gestation. Although levels may be different, it is still a good marker to use when monitoring cysts with indeterminate or suspicious features. A very high level may point towards malignancy, and stable or declining levels are more reassuring. So AFP and beta HCG, these tumors outside of pregnancy may be elevated in germ cell tumors. Placental and fetal production during pregnancy, however, is a future picture, and so they have limited value in pregnancy. LDH, serum levels of lactate dehydrogenase are unchanged in pregnancy. LDH is therefore a useful tumor marker during pregnancy. Elevated levels during being associated with certain germ cell tumors. So imaging modalities in pregnancy, ultrasound, MRI, and CT. So ultrasound remains a cornerstone of the diagnosis and follow-up of women with ovarian cysts in both the pregnant and non-pregnant state. It is inexpensive, safe, and readily available. A combination of trans-abdominal and transvaginal ultrasound using Doppler studies can be used to accurately diagnose ovarian lesions. Early identification of cysts at booking visits can help accurately classify cysts due to less shadowing or artifact from the gravid uterus. The sensitivity and specificity of ultrasound can be as high as 95 and 90% for the detection of ovarian cancer. The sonographic features used to classify ovarian lesions in a non-pregnant state can be applied in pregnancy. Although malignant tumors are generally associated with an increased vascular blood supply, with lower resistance and pulsatile indices of less than 1, an increased blood supply in pregnancy may limit the reliability of Doppler studies as compared to the non-pregnancy state. The absence of blood supply in the presence of ovarian lesion in a symptomatic patient is more concerning, as it could be a sign of torsion, which may need emergency treatment. The ultrasound features described by the IOTA Group International Ovarian Tumor Analysis are the most comprehensive. They are divided into B and M features that favor benign or malignant pathology, respectively. So IOTA features ovarian cyst, ultrasound views, unilocular cyst, presence of solid components where the largest solid component is less than 7 millimeters, presence of aqueous shadowing, smooth multilocular tumor with the largest diameter less than 100 millimeters, no blood flow. So M rules, irregular solid mass, solid component 80% of the tumor, presence of ascites, at least 4 papillary structures with a height equal or more than 3 millimeters, irregular multilocular solid tumor with a maximum diameter of more than 10 centimeters, strong vascularity. So in terms of MRI can be safely used in pregnancy due to lack of ionizing radiation. It provides superior resolution for axial masses as compared with CT. Although the movement of the fetus can interfere with the imaging, this can be mitigated by the use of fast imaging techniques. MRI can be helpful in the assessment of cyst, particularly if there are concerns with regard to malignant transformation of the cyst. So in terms of CT, a CT scan of the abdomen and pelvis can deliver up to 35 and 50 gray of fetal radiation respectively. Although effects of radiation exposure of less than 50 gauge of fetus at any gestation age are thought to be negligible, MRI still remains preferable. CT scanning will only be considered for a woman with an adnexial mass during pregnancy if widespread malignancy is suspected, so that spread to the lymph nodes and abdomen can be better assessed. So models to assess the risk of malignancy in pregnancy. So the RMI index is most widely used to determine the risk of malignancy outside of pregnancy. It uses the menopausal status, ultrasound features of the cyst, and CA1 to 5 levels to determine the risk of malignancy. However, this model has limited applications in pregnancy. The IOTO, International Ovarian Tumor Analysis Group, ultrasound rules for ovarian masses. This is a simple set of ultrasound findings that help classify ovarian masses into benign, malignant, indeterminate masses. These rules apply to ovarian masses that are not classical ovarian masses, which have pathognomic features on ultrasound. The group has published the largest study to date investigating the use of ultrasound in differentiating benign and malignant ovarian masses. This is based on 5 ultrasound features of malignancy and 5 features of benign lesion. And an axial mass is classified as malignant if at least 1 M features and no B features are present, and vice versa. Using these rules, the reported sensitivity has been 95% and specificity 91% for the detection of malignancy. So in terms of management, management for women with ovarian cyst in pregnancy needs to be individualized, taking into consideration the following factors: the nature and size of the cyst, the presenting symptoms, the gestational age of the patient, the impact it may have on the patient and the pregnancy, and vice versa. Broadly speaking, management of ovarian cyst in pregnancy can be either conservative or surgical. So conservative management, this form of management can be considered for most simple cysts, less than 6 centimeters, as the majority will regress over time. It is important that the initial scans appropriately describe the cyst, ideally using the IOTA system. Management may need to change if there is a change in the patient's symptoms or if the ultrasound findings progress. A reduction in the size of the cyst is always reassuring. An increase in size or the appearance of solid structures, papillary projections, or complex features may raise suspicion of malignancy. Stable cysts will most likely be benign. However, a borderline tumor must always be kept in mind. It is imperative that patients undergo surveillance during pregnancy be counseled about the need for surveillance postpartum as well. Rarely, depending on the size and nature of the cyst, the risk of torsion may increase postpartum. This is particularly the case with dermoid cysts. So surgical management. This form of management is to be considered if the patient is symptomatic from the ovarian cyst or when one suspects a complication such as torsion or hemorrhage into the cyst. The ideal time for surgery is around 14 to 16 weeks, as most physiological cysts would have resolved by that time. This gestation also offers the advantage of performing the procedure laparoscopically. Any surgery during pregnancy is associated with an increased risk of adverse outcomes, such as miscarriage or preterm birth. Although the exact risk is unclear, a large population-based study from Denmark by Rasmussen et al. Showed that the absolute risk of pregnancy loss was 8.2% for surgery against a background rate of 6.1%. For pregnancy loss, the risk was highest in the first week after surgery and leveled out after 2 weeks. The absolute risk of preterm birth was 8.3% following surgery against a background rate of 4.3%. So elective surgery is associated with a lower incidence of miscarriage and preterm birth when compared with emergency surgery. The risk to the pregnancy of surgical intervention needs to be balanced against the risk posed by deterioration of the patient's condition by delaying intervention, but due to a deterioration in the underlying condition in malignancy. So laparoscopy in pregnancy. Laparoscopy can be safely carried out in the first half of pregnancy, with an increased risk of injury to the gravid uterus after 20 weeks due to various entry or trocar insertions. It is important to remove the cyst intact and avoid causing intra-abdominal spill, which may cause seeding of the tumor if it is malignant, and any chemical peritonitis, which might result from spillage and increasing the risk of miscarriage and preterm delivery. Advantages of laparoscopic surgery include reduced hospital stay, less blood loss, and faster recovery. So good practice points for laparoscopy in pregnancy: experienced surgeon and anesthetist required, antacid prophylaxis, decompress the stomach using NG tube, left lateral to avoid iotocardial decompression, consider Palmer's point or supraumbilical entry, consider using operating pressures of 12 to 15 millimeters Hg, auscultate fetal heart prior to and after surgery. So laparotomy may be considered if the cyst is extremely large or if malignancy is suspected so that it can be removed intact and abdomen can be easily inspected. It is a method of choice in the third trimester of pregnancy. When operating in the third trimester, the plan for surgery should also include fetal monitoring before and after surgery. Conclusion: ovarian cysts are common in pregnancy and often spontaneously resolve. Management should be decided on the symptomatology and cyst characteristics. A wait-and-see strategy is advised for an ovarian cyst with benign features. Surgical management can be considered after 14 weeks of gestation to minimize intervention to physiological cysts such as corpus luteum cysts. Laparoscopy is safe in pregnancy but is to be used with caution, and laparotomy is preferred with large cysts and when malignancy is suspected. Thank you.
Thank you very much, Dr. Brichler. This was the first presentation for Dr. Moelle and Dr. Brichler. They just doing their contest for the first time, and then they did very well. So we're gonna open the floor for the comments and then questions.
Can only take 2 minutes, please. There's people outside.
Okay.
Yeah, just a minor, not serious. I don't think one should be doing speculums where speculum is not going to add any value. I'm just adding that. I mean, at this level, we're not students now. We just do speculums for now. But not every gynae patient or obstetric patient needs a speculum examination. That's the first thing. The second one, obviously, is with regard to somebody saying, I'll do a blood gas to get an HB. That doesn't sound quite right. Blood gas, arterial blood gas, is obviously to determine acid-base status of the patient. So just because some people are using a blood gas to get an HB, it's not the correct thing to say at a postgraduate level. You do an HB meter, that's what you use for that situation in terms of that. So I thought that I should just mention that in terms of at the registrar's level, one should not be saying things like that in terms of that.
Thanks very much, Dr. Maise.
Just 2 points that I wanted to say. One was that I think the one point was not highlighted, that there's an increase in risks with cyst in pregnancy because of assisted reproduction. There you said access to ultrasound, and I agree with that. The second point is that you did highlight the low risk of malignancy. However, we try to avoid surgery as much as possible in the first trimester. But if there is pain, suspicion, bleeding, or a risk of malignancy, you will operate in the first trimester. The fourth point down there, the other important point with the precautions in pregnancy, I mean, it stands to reason, but I mean, laparoscopy when you're operating is you don't use any manipulator because there's an intrauterine pregnancy. Never forget that. You avoid electrical energy. So that is why we operate with harmonic, which is ultrasonic energy, because electrical energy, if you're using a pad, remember current is flowing through the patient and it's always a so-called suspected risk. It may cause uterine activity. That's theoretical. Surgical management can be considered after 14 weeks of gestation to minimize intervention to physiological cysts such as corpus luteum. The issue is that, as you highlighted, the majority of the cysts, if you think are functional, will disappear by around about 14 weeks. The question comes in is that if the cyst persists after 14 weeks, say 15, 16, and the patient is asymptomatic, do you operate or do you not operate? Because the point you highlighted that if there is torsion or bleeding, it becomes emergency, and the risks associated with pregnancy loss with emergency is higher than that of elective surgery. So many of us, if the patient cyst, the cyst persists after 14, 16 weeks, I will operate in the laparoscopy, having discussed it with the patient, even if they're asymptomatic. So that's a big controversy. The best time to operate, as you said, operating laparoscopically is around about 16 to 22 weeks, because you get sufficient space to operate with. The pregnancy is unlikely to undergo an abortion or a miscarriage. And thirdly is that the pregnancy itself is well established. So that's why we operate between 14 to 22 weeks on these cases.
Thanks everyone. Today is a consultant meeting. Just to remind everyone about the oncology workshop in 2 weeks' time, highly subsidized. And I hope you guys are getting it on your WhatsApp, and on your emails. Are you?
Yes.
All right. Thanks everyone.
Okay. Yeah, you